Greetings and welcome to today's webinar on a total market approach for condom programming. My name is Lauren Alexanderson and I am the Knowledge Management Manager for the AIDS-Free Project. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations followed by a discussion period during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are visible only to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your technical questions for our speakers and save them for the discussion period. It is great that we are able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting steps if you have technology challenges today. If you lose connectivity or cannot close the webinar, re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. And just for those, it's jsi.adobeconnect.com/prevention. Use the Q&A box to ask AIDS-Free Tech for assistance. If the troubleshooting steps are not successful, please rest assured the webinar is being recorded and you will receive an email with a link to the recording following today's event. Questions that do not get answered during the Q&A sessions will be compiled after the webinar, shared with presenters, and responses from presenters will be shared with participants. To get us started, I will now turn it over to our moderator, Ivo Thior.
Thank you, Lauren. I would like to welcome and thank everybody for joining us today. My name is Ibu Thior, Senior HIV Prevention Technical Advisor for AIDS-Free. Today's webinar is organized by AIDS-Free. We have gathered thought leaders and implementers to discuss increasing the availability of, access to, and usage of condoms and family planning products and services in low and middle income countries. The speaker will share their research and implementation experience on total market approach for family planning and condom programming, which is very relevant for the new 20 by 20 initiative launched by the United Nations Population Fund, UNFPA, in collaboration with the World Bank, the Reproductive Health Supply Coalition, the United States Agency for International Development, Usaid, and the International Labour Organization. The goal of the initiative is to increase the availability, access, and usage of 20 billion condoms in low and middle income countries by the year 2020. I would now like to introduce our first speaker, Margaret Farrell of USA.
Good morning, everyone. I'm just waiting for my presentation to load. So today I'm going to talk about a total market approach for family planning. Now my focus is going to be a little bit different because we have really expanded a total market approach to look at family planning services. Most total market approach exercises focus on commodities or products, but this is an expansion of the concept to look at family planning services. Social marketing and donations by donors to ministries of health have really done a good job of getting short-term or resupply family planning methods through drug shops sometimes out to the last mile. What's really missing and a real choice and a real family planning method mix are long-acting and reversible contraception and also permanent methods. So we really expanded this concept of total market approaches in the Office of Population and Reproductive Health to really look at services which we thought were the main barriers to true choice and method mix for clients. So what is the total market approach? It's the rational use of all segments, public and private, to provide health products and services equitably. Our office has decided that total market approaches is one of our Office of Population and Reproductive Health focal areas. I'll also touch on the importance of sustainability and scale-up briefly in this presentation. A total market approach brings all of our service delivery areas together. Some of you are maybe new to this concept, but most of you are likely thinking with a total market lens in your program. I know of many programs that only focus on the public sector. I don't know of many programs that only focus on the public sector or the private sector. Most systems are mixed public-private systems. If a program does only focus on one sector, it may be because they're complementing work by other donors and aiming not to duplicate. This is also an important component of a total market approach in practice. And for us, the definition of private sector really is public, nonprofit, and for-profit. That includes the public sector, providing maybe donated products to the poorest of the poor. The nonprofit sector includes NGOs, faith-based organizations, and even informal sector. And for-profit is the true commercial part of the private sector. You may have heard the term whole market approach. We're really talking about the family planning market. These are the key pieces of the market: the methods, the clients, and the sources or the providers. And we are talking both about the current market and the potential future market. We can look at the past to understand the past market and what aspects have changed and why. What has stayed the same? The market is always dynamic and changes. Health systems evolve and are very dynamic. All of these dimensions are subject to change. But what we really want is a healthy market. There are enough services and products in the right places for diverse clients and their needs, that they're affordable, and that even at the last mile, underserved populations can access these services and products. The market is generally discussed as supply, but another real contribution I think we've made to this total market approach is to see that demand greatly influences it. We as a community can grow demand in countries for all family planning in general, for services in different sectors, and for new or underused methods. So a lot of TMA really looks at supply, but I'm saying demand is also a really important component, especially in family planning and with methods that often have little or low knowledge in countries. So in a series of questions, we have laid out how to think about total market approaches in a programmatic context. Are we maximizing the participation of all the actors, the public sector, the nonprofit, the faith-based, the commercial sector? Which populations are each of these serving and where? Can the clients afford to pay? Do the clients pay? Is there enough income to generate cost recovery? Who is serving the poorest? Are there any clients who aren't being served with methods, specific methods? What types of service delivery approaches can do each of these best? And how can we, most importantly, in many of the countries in sub-Saharan Africa that we work in, how can we really grow the whole family planning market? We want to make sure that when we graduate, when Usaid graduates its assistants from countries because they've done such a good job in programming, that family planning will still be provided. So here are the income quintiles. This is just to give you an idea of how to think about this. You know, Q1 represents the extreme poor, Q5, the final or richest quintile. It's important that as you think about the family planning market to look at the demographic and health service data for FP by income quintile, by modern contraceptive prevalence rates, and by total fertility rates. And look at the differentials between the quintiles, as well as other indicators, such as the source of data in the DHS, where people go for various different methods, public or private. Also look at these differences for education and rural-urban. In general, in a total market approach, Q1, the very poor, should be served by free products and services. Q2 and 3 are perhaps the social marketing segment or the social franchising segment, which really is social marketing. Social franchising is really social marketing for services. So Q2 and Q3 need some subsidy to be able to access products. Q4 perhaps could have manufacturer's model product. We have a product, wire, microgynon FE, that we've introduced in 11 sub-Saharan African countries. It's at a fairly affordable price for a Q4. It's at 75 cents to $1 a cycle instead of usually the $6 per cycle that real commercial oral contraceptives charge in sub-Saharan African markets. And then Q5, the wealthiest, they generally have the ability and are willing to pay. But when you look at the actual data about where these different quintiles are going for products and services, you can often see that Q5 is going to the public sector for free. Q1's usually completely underserved. It may not even have any health posts or health clinics in its area, in its geographic area. I'm going to present a series of case studies to think about a total market approach to family planning. Here we have Morocco. In the mid-1990s, the National Family Planning Program established in Morocco had made significant improvements in contraceptive access and use through both the public and private sectors. In 1995, the Moroccan government faced growing economic constraints, and they desired that family planning services be centralized to the local level. They sought to preserve their role as a service provider, but they wanted to do it in an economically sustainable fashion. Usaid funded a market segmentation study to identify the relative size of consumer segments based on their choice of contraceptive method, their choice of public versus private, and the level of unmet need. The analysis found a mismatch between older women's desire not to have additional children and the low use of long-term contraceptive methods, IUDs and female sterilization at the time. Based on the medium to high economic status of both older city dwellers and older working class, the study highlighted the opportunity for the private sector providers to play a larger role in the provision of long-term methods in urban areas, while the government targeted its subsidies to rural areas to reduce barriers for poor women who wanted to contracept but weren't contracepting. Here's another quick case study about total market approaches in Malawi for family planning. There's long-standing MOH support of NGO family planning provision. There's contracts with faith-based organizations, the Christian Health Association of Malawi. The government, really, the Ministry of Health serves as a steward and has contracts with these faith-based providers for family planning. And the ministry both finances these contracts and oversees their implementation. There was a big push for task sharing for clinical officers to provide permanent methods and for community health workers to provide injectables. They worked through their facilities and they made sure there was free family planning services at the community level. They used Marie Stopes International for mobile clinical outreach to rural areas and also social franchising, the STAR network. And there's CBD of injectables and other methods. So you can see in Malawi, the modern contraceptive prevalence rate increased from 7% in 1992 to 42% in 2010. And they also have to be the country with one of the largest, in sub-Saharan Africa, with the largest use of voluntary female sterilization. One more quick example of TMA for services is Bangladesh. Bangladesh was one of the first countries in the world to show that even a poor country with low levels of education could have increases in even poor people using family planning when there's a strong family planning program. MATLAB provided doorstep NGO short-term methods, pills and condoms, by public lady health visitors. This doorstep delivery was discontinued in the 1990s. And it really morphed into social marketing. they have the world's largest social marketing organization, a social marketing company. It sales of pills, condoms, injectables, IUDs, and implants, and it's responsible for about 35% of the modern contraceptive prevalence rate in 2007. There's a lot of family planning in multiple private channels, drug shops, pharmacies, clinics, social franchises. And the SHOPS project, which was our previous flagship project, worked on adding private LARCs and PMs into private maternity hospitals. There was a proliferation of private maternity hospitals, and more people started going to those hospitals for their delivery services. And so SHOPS added LARCs and PMs, which they really didn't have until then. I just want to focus on the fact that it also took the Social Marketing Corporation 20 years to become fully sustainable. I think there's a lot of donor fatigue with social marketing organizations sometimes, but it takes a long-term commitment to building capacity in organizations before they become sustainable. You can't start a social marketing organization and decide that you're going to shut it off in 5 years. It's just kind of a waste of the taxpayers' resources. So moving on, because I've gotten my warning and I don't want to take the other speaker's time, I wanted to talk about sustainability briefly. You know, there's a lot of ways to look at sustainability. Some people think you have to sustain everything you're doing right now. That's not necessarily true because health systems completely evolve and change the way they deliver services over time. I explained how there used to be doorstep delivery in Bangladesh of resupply methods, but that morphed into social marketing later. Later, that could morph into true commercial provision when there's very high use, and maybe there's a UHC that's providing financing for people to be able to get their products and services. The most important form of sustainability is that people have a norm, that a norm is changed, that people contracept at the population level. That's a norm that doesn't change. PEPFAR doesn't usually go up. MCPR doesn't usually go down. It may stagnate or plateau, but MCPR, modern contraceptive prevalence rate, doesn't usually change once it gets very high. So these are questions to think about as you think about total market approaches in your country. How effective are all the service delivery approaches? Are they reaching new clients? Who are those clients? Does it help clients switch between methods according to their reproductive intentions and their life cycle? Which ages are using which contraceptive methods? Segment it by age and see if there's differences. Are poor, underserved, vulnerable populations truly reached with a wide method choice? How widely available are the different methods, and through which service delivery approaches? Public, private, NGO, faith-based? And are integrated services improving both outcomes? Sometimes when there's integrated services, family planning gets lost. So it's important to make sure that in an integrated service delivery package, family planning is still a priority. I want to quickly mention 2 e-learnings that we developed recently on our TMA working group. We have a total market approaches for services and a total market approaches for products. We also have a social marketing e-learning. We have a private sector e-learning. We have financing for health e-learning, which is about credit. We have a social franchising e-learning. These are all on the AID e-learning courses platform, which are completely open to everyone. So I encourage you to take those courses online. Thank you.
Thank you, Margaret. For our attendees, add your question for Margaret in the question and ask box for our discussion session. The next presentation is from Dr. Kim Green of PATH.
Great, thank you, Ibu. So I'll be providing a case study on the total market approach in Vietnam. So first off, why the total market approach in Vietnam and why now? The HIV response in Vietnam is really at a crossroads. The epidemic is concentrated in key populations. And through PEPFAR support, Global Fund, and other major donors, the Ministry of Health's prevention and treatment efforts have contributed to a steady decline in new HIV infections. And with these results, the Ministry of Health has embraced the 90-90-90 targets by 2020 and elimination of HIV by 2030. However, there is a significant and major challenge which is faced by the Ministry of Health and key implementers, which is that nearly 80% of the national program is funded by external donors. And so what's happened is with Vietnam attaining middle income status in 2009, a number of major donors have left or have dramatically reduced the size and the geographic scope of those programs. And that, of course, has also influenced the numbers of free and socially marketed condoms that are available in Vietnam. And so this comes with both good news and bad news. The good news is that with the reduction of subsidized condoms, there's been further growth in the commercial market. And there are also local condom manufacturers in Vietnam, and they had previously manufactured in Vietnam, but only for export to other countries. So with these shifts, we've also seen local manufacturers seeing an opportunity to invest in their own local market, which is exciting. And then, of course, with economic growth, we see increasing purchasing power and willingness and preference to pay, particularly in urban areas. And of course, with good news also comes bad news. The bad news is that there's a Wild West condom market. The market's unregulated, and there are no mandatory standards that apply. So what's happened is that there's now an abundance of low quality and fake products. There was a study done in 2014 through UNFPA and Crown Agents. And what they found is that nearly 50% of the condoms in the wholesale market were substandard, which is clearly a huge concern. So I want to turn now to the PATH Usaid Healthy Markets Project and TMA efforts. The Healthy Markets Project is a 5-year initiative funded by USAID, started in 2014, and it's part of the PEPFAR effort in transition, supporting the Vietnam government in sustainable financing, now that it's a middle-income country. There are 3 key objectives. The first is really in leveraging private sector engagement and investment. The second is on demand generation for HIV goods and services, whether they be free, partially subsidized, or commercial. And then the third element really focuses on increasing sustainable supply for HIV goods and services, and that's where I will place most of the emphasis for this presentation. In our strategy, there are 4 key elements that we utilize for sustainability. The first, of course, is the total market approach. And we're really using a lot of experience that PATH has generated in a number of countries through family planning with TMA, including in Vietnam, in how to generate data and how to better segment populations to balance access and equity. We're also applying, of course, basic marketing principles to race, selling them in the right location, and doing the right promotion. A third element of our work has been in partnership with the private sector, both through CSR efforts, but also in a shared values and co-creation space, which has been really interesting. And the fourth element, which is very exciting, is social enterprise. This is an evolving area in Vietnam, and some of our key collaborators are social enterprises that distribute or retail condoms. So now I want to focus on our TMA goals and some of the steps that we've undertaken. There have been 4 key goals that have guided our work. The first has been supporting a transition from free and partially subsidized dominated condom approach to a true TMA with access to commercial products for populations affected by HIV. The second that's linked to that is really identifying commercially viable ways to reach key populations with affordable and preferred condom brands. And also importantly, operating on a national level, working with the Ministry of Health to help them with rational commodity planning and targeting subsidized condoms to those who need them most. And of course, as Marguerite also mentioned, the very important element of demand generation. So for us, our efforts in Vietnam have really been concentrated, I'd say, in 3 key categories. The first has been really understanding the context, really in terms of policy enablers and barriers, primarily towards condom regulation and quality issues. That's been really key. The second has been in understanding the actual market. What's the volume of condoms? that are sold, their value, their growth, and also understanding key distribution networks. And the third has been measuring consumer condom use, their preferences, and willingness to pay. The second area has focused on supply and demand. So that's been partnering with the local condom manufacturers and distributors to brand and deliver quality, affordable condoms to key populations. And then also, of course, working on the demand side. And then the third element is focused on policy and planning. So advocating for those condom quality standards, but also working together with national and provincial HIV leaders to utilize the TMA to plan and prioritize how to use their limited resources. So I want to focus on a couple of key areas of our work. The first is market analysis and segmentation. In looking at condom volume and growth, we looked at data from 2010 to 2014. We also looked at data before 2010. And what we can see is although there's been uneven growth in the commercial sector, the proportion of volume of commercial brands has increased and sales has increased. 2014, about 80% of the share of the market was commercial, and we see something very similar in 2015. And also in forecasting, we see a relatively consistent and steady growth in the commercial condom market. Now turning to consumer behavior and willingness to pay, we conducted a study in 6 high HIV prevalence provinces. And there we looked at those that were using condoms, what were they doing most of the time in terms of procuring them. And so we found that the majority of key populations that were procuring condoms were buying commercial condoms, between 2/3 and 3/4. And then we also looked at willingness to pay, and here we see that the majority of individuals were willing to pay a commercial price, which is around 2,000 DOM, or about 8 cents per condom. And there was also a significant proportion that were willing to pay more than that. So I want to turn now to look at the development of local condom brands and the distribution system. We've worked with two WHO pre-qualified local condom manufacturers, and they've been utilizing the market research that's been generated to either develop new brands or to utilize brands that they've used in other markets. So 2 of those brands have launched, and about 10 million condoms have been sold through the commercial distribution system. And I wanted to focus specifically on one of those condoms, condom brands that have newly launched. The brand name is Galant. It's manufactured by Medivice 3S. And what's really interesting is the approach that's been undertaken to reach both key populations and the wider market. So they've sold condoms to a traditional condom distributor, Dumio, that's distributing to traditional outlets and non-traditional outlets. So that's a very typical way for distribution to occur. But at the same time, they're also selling directly to key population community-based organizations who are then selling condoms to key population clients, also selling within hotspots such as through pharmacies. And there's a burgeoning and growing online business for condom sales. And the third piece that's been really interesting has been working with social enterprises. So one is called Condo Home, and they're retailing condoms online to men who have sex with men and to young men. And also a company called Dragon Fruit that's developing an app called Grab Condom, which is a condom storage geolocator. So some final thoughts. I think what's been interesting in Vietnam has been our efforts to seed innovation. We've utilized an innovation fund which has invested in some really interesting and creative ideas across the distribution retail value chain. The second is by working in a vibrant and dynamic economy, there's been a number of private sector partners we've been able to leverage and engage with. One of them is MTV. They've been a great partner. They've offered free airtime and creative and are doing some really fun and innovative work. But also we've been able to leverage from the condom manufacturers themselves, Medivice 3S. They distribute condoms to the community-based organizations and also offer them an access price. The third key element really has been this emphasis on quality. As I mentioned at the beginning, quality is a huge challenge. The terrain related to quality and regulations, fortunately, is changing. There's a decree which has just come into place, which will change things once I would say in the next couple of years, once the regulation has teeth. But we've been working in the meantime on a condom quality seal, partnering with anti-counterfeiting authorities, and also implementing consumer education. I want to very quickly acknowledge our amazing partners through the Ministry of Health, through USAID, our research partners, our partners in the value chain, media, and of course, great colleagues at PATH. Thank you very much.
Is from Dr. Douglas Evans from George Washington University.
Yes, hi everyone. Doug Evans here. I'll just apologize in advance. I'm a little bit under the weather, so my voice is probably a bit scratchy, but hopefully I'll be able to carry on. Thanks very much. I'm going to talk about, first of all, my overall work on the use of branding principles and brand research methods, and then link that to the total market approach and focus on two case studies of research that I've done in recent years related to the total market approach for condom programming. So this slide basically illustrates the idea behind a brand. I think we're all familiar with the idea of brands, obviously, from the commercial sector. And brands at their base consist of three things, which is a position. Brands stand for something. They represent values that a consumer may associate with. And the basic idea of associations is at the core of branding. There's a quote here from Tim Calkins, an excellent volume from the Kellogg School of Management from a number of years ago on branding. Brand is a set of associations, so in other words, mental representation linked to a name, mark, or symbol associated with a product or a service. A name becomes a brand when people link it to other things. So brands stand for something. They also represent something to the audience, so they have a kind of persona. You can think of brands as having a personality, just like a person would. And in fact, people are themselves brands. We're all brands in a way. We all have reputations that people associate with us. And so brands themselves, so organizations, products, services, and behaviors in particular, all can have personalities. And then those are the things that we control. And then finally, there is how we implement that in the real world, how we execute our brand. And this is something, obviously, that we have some control over. We create advertisements. We do marketing efforts. In the case of condoms, we're distributing our condoms and promoting them and placing them in various ways. But the audience experiences that, and that experience is going to have an effect on their reactions and their behavior. And the main thing I want to point out is that behaviors like condom use, the category of condom use, can also be branded. And so I think this is an important insight. I think we understand this in social marketing, but in the wider world of public health and promotion of health, it's not always that well understood. So we can brand behavior as much as we can brand products, and we can use products like condom brands to create more positive associations with the behaviors that underlie them. So this slide basically illustrates that that this idea of health branding, as I'm calling it, so the branding of health behaviors, is based in behavioral theory. Brands create what I call positive brand equity, which is basically a measurement scale. It's a multidimensional construct, and that construct is based in existing behavioral theories, specifically social cognitive theory and the integrated model, which is the final version of the theory of planned behavior. Might be a little bit more familiar term to some people. And I've written about this in a recent book of mine that's cited at the bottom of this page. Basically, health branding specifies the social role modeling component of social cognitive theory. Basically, in health branding, we show people engaging in a behavior, modeling the behavior, and this provides a specific role model that people can follow. And it also specifies the attitude component of the integrated model. Basically, the idea that changes in attitudes targeted by health messages are themselves affected by brand equity. So this brand equity construct is kind of a mediator. It's basically an explanation of why people engage in behaviors, why they specifically use brands such as specific condom brands or engage in condom use. And this would apply equally to many other behaviors that we've been talking about, family planning here today, and other health behaviors that would be of interest to the audience here today. Basically, I think of brands as being tools for intervention. They are a way of changing behavior. They're also tools for recruitment into programs, getting people to participate and engage in our programs, and also for translation and dissemination. This is just a little model that sort of illustrates the idea that I'm talking about. The key thing to note here is that this notion of brand equity, we expose people to our social marketing efforts, to our, for example, condom brands in countries like Vietnam or other case studies that we've been talking about, and that creates associations. Hopefully they're positive ones. We see role models using the condom brands. We form positive associations, and that predicts subsequent outcomes. More positive social norms, for example, about condom use, and that can increase intentions to condom use, for example, and it can reduce risk behaviors. The other thing that this model shows is that we can think of more complex lifestyles and brands. One of the powerful things about brands is address multiple co-occurring behaviors. So things like co-occurring substance use and HIV risk can potentially be addressed through one brand, as opposed to many of our programs, especially in the public health world, tend to be vertical. They're addressing one content area or subject matter. One of the powers of brands is that it can address whole lifestyles. So what I'm going to do is illustrate the use of this brand equity construct and brand research with two case studies briefly. And the first one is from a study that I did a few years ago in Zimbabwe. And it's an evaluation of the Protector Plus condom brand in Zimbabwe. So this slide kind of illustrates the basic questions that we had in the study. How can we use all of the 4 Ps of marketing, so product, price, place, and promotion, as I'm sure we're aware in this call, to create socially marketed condom brands that people actually want to buy. And this study was published, by the way, in BMC Reproductive Health, if you're interested. So we had an interesting, naturally occurring kind of experimental condition, if you will, in Zimbabwe, that they increased the socially marketed prices significantly in 2009. And they also converted to the dollar, pegging their currency to the dollar, which effectively greatly increased the cost of condoms and other products. And we wanted to see basically what effect this price increase and whether Zimbabweans were willing to pay more for condoms, and what the potential effect on TMA would be in Zimbabwe. Obviously, there are both free and socially marketed and some limited availability of commercially marketed condom products in Zimbabwe. So we were interested in looking at this, the effects of this in that context. And this is just a quick illustration of our study design. We were comparing current and former users or lapsed users of both the Protector Plus brand and the free or government sector brand, and then also looking at non-users as essentially a control group. And this slide basically just shows some results from the study. In the left-hand column, we have a number of brand equity factors. So these are some concepts that are probably pretty familiar to us: the idea of brand loyalty, perceived quality, whether the brand is a leader in its category, how valuable, what is the perceived value of the product. Also this idea of brand personality, sort of what does the brand represent to you. This is all with respect to the Protector Plus brand. And then also market barriers. I'm going to move quickly through all this because I know I don't have a lot of time. Basically what we see is that some of these factors are associated with higher willingness to pay. In particular, in the Protector Plus columns, you'll see that there are positive, higher odds ratios for several of the brand equity factors. basically, people have higher brand equity. They're more bought in. They have more positive associations with the brand. They're willing to pay for Protector Plus, and they're also they would be more willing to pay for condoms even if they're users of the free and government sector brands. So regardless of their current usage, they would be willing to pay more. This has implications, obviously, in that price is not necessarily a barrier to usage, and brand equity predicts that. So I'm going to give you quickly another case study of another program. This was a review of a number of country programs that are being implemented by PSI. And basically the goal of this study that was done in 2013 was to understand the effect of brand management on basically the total market for specifically for condoms, and how social marketing brand management can be defined and how it can be a positive influence on the growth of healthy markets. So basically what we did was a retrospective analysis of a number of brand management actions that can affect the health of markets in several countries: Kenya, Madagascar, Mozambique, Nigeria, and Tanzania. They were chosen based on comparability in terms of the type of social marketing platform they had, and also per capita GDP levels being reasonably comparable. And we used existing national data sets like the DHS and other available data sets. Basically what we wanted to do was also account for variation in the markets over time, like changes in funding levels, media implementation, and so forth. And what we did was develop a composite measure of brand management, and we attempted to account for the type and reach and frequency of brand management activities in the country. So we were looking at the relationship between how active was the brand management and what effect that had on the total market. So we basically used a mixed methods approach. We developed a coding scheme to quantify brand management actions. We weighted these equally, and we then conducted both quantitative and qualitative analysis. I'm just going to mention the quantitative, where we did regressions and we looked at consistent condom use with commercial sex workers and condom use at last sex. And then we looked at this brand management factor and some covariates to see what effect they had. When we ran into some challenges, there was a lack of DHS data during all the periods of interest, so there wasn't all the data available that we would have liked. We also detailed brand management data by year and reach, where it was delivered, and also frequency and intensity, how much and how often. But basically what we were aiming to do was demonstrate a methodology that can be used to understand the relationship between brand management and the effect on total market. And basically we use multivariable analysis methods, and we were looking at an indicator where the predictor was a dichotomous indicator of awareness of brand, and we also took a number of covariates into account, as I mentioned. So basically, real quickly, this slide shows that there was a positive relationship between awareness of the brand. It predicted condom use at last intercourse. And also, if funding, there was also a negative relationship. The lower the funding was, the lower condom use was at last intercourse. And also, there was an effect of education. So higher levels of education predicted condom use. And I'm going through this very quickly because of time, sorry. We also found when we combined the years of analysis, there were similar effects that, as we might expect, awareness of the brand management activities predicted more condom use, and lower funding levels in the program zone, that would be the area of the country that was being analyzed, predicted lower condom use. And we also saw a positive effect of education. So basically, we do see that brands are being actively managed in these countries, and we see a relationship between active brand management and the behavior being targeted, namely consistent condom use in this case. But we definitely need better data on brand management, on implementation, like reach and frequency of activities, and also cost and location of activities. Without these kinds of detailed data, it's difficult to determine an exact effect of brand management, but this is clearly a promising area. If we have better understanding of our brand management and implementation activities, we're going to be able to get a better assessment of the effects on the total market in countries. So we do have a methodology now that can be applied over time, but we need better data collection and brand management systems in order to do this. And this methodology can potentially be used fruitfully if we are able to develop better monitoring systems. Thank you very much.
Thank you for the explanation. We have almost close to 15 minutes to time for discussion. Please type your question for our presenter into the question and answer box. We will try to get to as many questions in the time we have remaining. So the first question is from Giovanni. How do you measure condom value and volume, especially in the commercial sector? And I think Kim probably you would be able to address that question for Giovanni.
Yeah, hi Giovanni. So what I'm going to do is I'll provide the answer, but then if you have provided your email address to the organizers, then I can send the methodology to you so you have it in full detail. So for market value, I'm sure you're familiar with the calculation. The total market value equals the volume of imports plus volume of local manufactured condoms minus volume of exports plus the volume of the gray market. And for market value, we're looking at the volume of each brand per year times the price of each brand per year. So the methods that were used to gather that data included primary data collection, and this was done through Ipsos, which is a market research firm. And they have experience in the condom market in Vietnam, which is very helpful. So they interviewed and talked with local manufacturers, importers, distributors, retailers, and opinion leaders. But then they also gathered secondary data, such as through IMS, which looks at condom sales through pharmacies and through the healthcare system in general, and then looked at consumer studies that had been done previously looking at the condom market, and then applied their mix of methodologies, which included the Delphi panel of experts and a number of other techniques. So it's quite a lot was done to come up with a calculation, and certainly it's challenging to do, but it's essential. So I'll make sure that you get the detailed methodology. Thanks.
Thank you, Kim. We'll go to the next, the second question. This is from Kadirov. What role should a social marketing organization play in fostering the TMA agenda? I think probably Margaret, you can address that question.
Thank you. So I think social marketing programs are very invested in TMA. PSI has their own TMA methodology that they're using that I'm sure Kim and Yasmin, who are on this, who are participants, could further elaborate on. But I just want to say it's very context specific. You have to look at what is the modern contraceptive prevalence in this country. Is it low prevalence? Is it medium low? Is it mid? Or is it high? It's a different answer for each of those. Because social marketing really builds demand. It builds the overall market and grows the market. People pay something even though it's a nominal amount, and you can use that money to reinvest in promotion and demand side activities. You need to look at the poor and the near poor and what channels they're using. How are they accessing their methods? Is the MOH really delivering free methods with no stockouts to the last mile? That's an important question. Also look at the existing commercial products and the price points. This may be different for condoms, as I've seen in countries, but for most of the other products, the price points are quite high for injectables and oral contraceptives and progestin-only pills, combined oral contraceptives, and also for EC. And I haven't really seen the commercial sector robustly investing in the demand side. They're just not willing currently, I think, and that's in very, low prevalence markets. They're not really doing the formative research to look at the barriers, the misperceptions, and really addressing those through whether it's mass media, mid-media, or interpersonal communication or community events. And social marketing is really priming the market for future commercial products. It's a real service that's being done for a lot of these pharma companies and generic companies. So you have to have a long-term view when you think about this. Also, some of these social marketing organizations have commercial products, and they're using those products to cross-subsidize products for the poor. So that's an important function. A lot of these social marketing organizations will become independent local organizations, local NGOs. So they're part of the in-country capacity, if you will. So I think you need to think about all of these things. If you have good answers to all of these questions and the prevalence is high to mid-high, maybe it's time to kind of phase out some of the subsidies to the commercial sector. But you better make sure that the poor really do have access.
Thank you. The next question probably will be, Doug probably will try to answer that question. Should we consider branding public sector condom for free distribution? If so, how will branding of free condom help the TMA agenda?
I definitely think that, my research and the broader work that's been done on branding in the social marketing sector definitely shows that branding is a predictor of behavior. Effective branding can increase adoption of behavior. It can clearly increase adoption of product use in socially marketed products. I think the work that we did in Zimbabwe definitely shows that brand perceptions, brand equity as I call it, can have a significant effect on not only socially marketed paid condoms, subsidized, but also those that are freely available in the public sector. I think the key is the creation of perceptions of value for freely available condoms. I think that the importance of that is, we have to stop and think. I mean, people infer value based on cost to a certain extent. Higher prices is often equated with perceptions of higher value. So I think one challenge we face is how do we make freely available condoms perceived as being valuable? What other forms of value can we associate with them? So I think there are some unique branding challenges that face us when we think about freely available condoms within the overall context of socially marketed condoms. But I think we can definitely overcome those, and we do have some preliminary evidence that suggests that branding freely available condoms can be effective in increasing those value perceptions. And we would, given what we know about the effects of brands overall, we would expect that to increase use. So I think it is an important area, and I think it's part of the total market approach because clearly there are going to be different levels of ability to pay. Willingness to pay is one thing, but the previous discussant was talking about people's ability to pay, and I think we have to take that into consideration as well. So all of those things are important, but I do think that branding can be a very effective strategy for increasing usage not only of socially marketed condoms, but also freely available as well.
Thank you. There's a general question, very interesting. I think anybody who have an answer can try to address it. Any information for how total market approaches for condom programming apply to things like female condom and Zika?
Yeah, this is Kim. I can take the female condom part of the question. The female condom got off to a bit of a rough start, and maybe part of that had to do with price point, but also branding. But now there's a new generation of efforts around the female condom applying TMA. PATH is working with a condom manufacturer in China, manufacturing a female condom at a lower price, and working on the branding and market entry. And if you're interested in that, I would be happy to link you to further information. But the same approach is really applying of, offering it free to the right population, offering subsidies to the right population, and also offering it through commercial channels as well.
Anybody else to chip in? Okay, we'll go to the next one. This one is, I would like to know more how dimension can drive TMA. This is new to me. So how demand generation can drive TMA? Anybody? Kim, Margaret, Doug?
I'm thinking of Doug since he's focusing on branding.
Yeah, and I was just going to say briefly, I mean, that's a big question, but certainly what brands are all about is increasing demand and also essentially framing choices. So, the first thing that a brand has to try to do is make people aware of it. But then once people are aware of it, to try to frame choices, either to engage in our case, the healthier behavior, or to avoid the unhealthy behavior, and then specifically, if we're marketing a socially marketed product, to choose our product. But yeah, I mean, brands are about demand creation. They're about getting people to associate positive value with engaging in a behavior or the use of a specific product. And so I think that it's a very powerful tool for creating demand. It's getting people to recognize that there's a benefit, that they're going to get something out of the behavior. And so I think that this is really, one of the key things. We need to use our branding efforts very basically in order to increase demand. But that is one of the essential functions of branding. So I think that, we have opportunities to do that. Some of it involves actually reaching people, where they are, and realizing that our audiences are in different places physically, but also mentally in terms of their, barriers to entry into engaging in behaviors, and that requires us to use multiple promotional strategies. So I think we have to be creative. I also think we have to look at what the commercial sector does, and recognize that, we may have a brand position. Our Protector Plus brand in Zimbabwe, for example, represents something, but we can market and promote that in different ways to different audiences. So there are a number of strategies like this that I think we can use for branding to increase demand.
Thank you, Doug. We want to keep this webinar for 1 hour, so I think we have 4 minutes left, and we'll address 2 questions. The remaining of the question can be addressed offline after the webinar. So the next one is for Margaret. For Quintile 5, is there an impact from these high earners who will also be high taxpayer and expect to get free product as they have paid their taxes?
This is an excellent question. It's something I argue all the time. We and the health economists are trying to make sure the subsidy goes to the poorest people from the public sector. But the truth is, the resources and the financing to fund that comes from the taxpayers, who are mostly formal sector workers and upper income folks in the upper income quintiles anyways. So, I think it's very germane to this whole push for universal health coverage and how schemes are set up. Many of them add formal sector workers first, traditionally and historically, and then later added lower income and informal sector workers. But I think some of the rollouts in sub-Saharan Africa are trying to add the poor sooner. So, if you're going to do a UHC system or some kind of social insurance pooled risk pooling, that can be different. That can make sure that everyone gets what they need, or everyone, maybe the poor get it for free, and there's some kind of copay by the upper quintiles. But this was really talking about what's happening today, here, right now, before 5 different evolutions of a UHC system in a country, because generally they keep evolving, and saying, what can we do now to make sure the poor, who suffer the most excess mortality and morbidity from unintended pregnancy, what can we do today to make sure that we can improve health outcomes?
Thank you. So I will say the last question. I think also there's somebody who asked for Kim to share the methodology for the rest of the group. I think we'll address that offline. by just using the email system and sharing the links. So the last question is, what is being done to attract commercial sector to invest directly in developing markets?
So this is Maggie. I could talk a little bit about our BEAR project in 2 sentences, and then others could fill in. Is that okay, Ibu?
Yeah.
So we have a project with Bayer Pharma in 11 sub-Saharan African countries that's using the manufacturer's model. We're investing for 5 years in demand-side subsidy, and Bayer, for perpetuity, has promised us a low-price microgynon FE COC combined oral contraceptive for 75 cents to $1. So we've introduced this now in 11 countries, and we've subsidized the demand side, and our project is closing in September, and they're going to keep that product at that low price in these markets, and we're going to be monitoring and seeing how well they'll be products because the subsidy is over. We'll see how well they do. And they're about, usually the other BEAR pills are $5 to $6 in most of these African markets. So this is like 75 cents to $1, so it's significantly less, but I won't say that it's a quintile 1 or 2 product.
Thank you. I know also for the 2020 initiative, which is really to provide 20 billion condoms by 2020, the commercial sector is on board. They were invited to several meetings right now to see how they can be involved in developing markets. And I think there is a series of studies that Aid-Free will be doing, and those studies will help also in addition to additional studies that even the private sector themselves would like to carry out to understand better the market and see where, what is their place in those developing markets, specifically when it refers to condoms.
Yeah,
so before we wrap up, yeah, go ahead.
No, I was just going to add, I think that the data is really important because I think a number of the commercial manufacturers, condoms, the previous trend, and this was needed at the time, there were a large quantity of free and highly subsidized condoms, and a lot of those commercial manufacturers might not have seen the market, so that's why they weren't investing. But by generating that market data, by applying the manufacturer model, and by addressing some of the quality issues, the regulations, I think that can provide a really strong environment to incentivize investment.
Thank you. So before we wrap up, we would like to again thank all the participants for giving their time and expertise today. In the next few days, you will be receiving an email with a link to today's recording. Before we close the webinar, I wanted to encourage you to take a moment to fill out the poll questions below, as the feedback helps us to improve future webinars. I would also like to encourage you to subscribe to the Aid-Free Prevention Update. The link to subscribe is now on your screen. Thank you all once again.